Dr. Wolski, again, there's a new, a relatively new buzzword out there, RSD, an illness or symptom, simply because some famous person, I guess, got it, and most of us have no clue what the heck it is. Anyway, how do you diagnose it? How do we people know that we might have it? What are the symptoms?
Well, the symptoms are having pain way beyond what it should be. For example, if you have a carpal tunnel surgery, that should heal up in about 6 weeks. People with RSD, they have pain, unbearable pain after surgery for years. If you have a broken bone in your hand or a crushed injury to your hand, that should clear up in 6 to 12 weeks. These people have pain for years, and this is unbearable pain. It's pain to light touch. If you barely touch these people's skin on their hand or their foot, they just recoil from pain. And what we do to help diagnose these, usually they've been to 3 or 4 doctors before us, and a lot of doctors think that these people are just crazy. What we do is look for signs like purple skin or blotchy skin, swelling, sweating of the hands, and you have to diagnose this thing. First of all, it's a diagnosis of exclusion. You have to diagnose other illnesses that could cause nerve pain, and one of the commonest ones is diabetes. You can get a diabetic neuropathy where the nerves are damaged by the diabetes and it causes unbearable pain in the hands or legs. What we do is an EMG NCV study, which checks the speed of the signals in the nerves. We put needles in the patient's muscles and check the speed of the nerves. And
is that kind of like what's known as a nerve conductivity test or something like that?
Exactly. Yeah, you're right on. We do an EMG which checks muscle signals, and what those tests, they can tell us if the patient's got a nerve problem from diabetes or another injury. Usually in people with RSD, this is a negative test. Sometimes, usually the diagnosis is almost 100% clinical, but we can do tests like in about 30 to 50% of the time, patients have a positive bone scan. We have a thermogram in our office, which will show temperature changes. It'll show temperature changes between the limbs, and that's one of the hallmarks for RSD. Like one hand might be colder than the other. We can do X-rays. A lot of these people have osteoporosis or less calcium in the bones. After we make the diagnosis, we have a multidisciplinary program where we can treat the patient for the pain.
Okay. So basically, testing and eliminating what it is not is a major strategy in that. Kind of like, it's not that, it's not that, it's not that, and by doing so, we find out what it basically is. So it's not so much finding what it is, it's rather eliminating everything possibly which it could be, and by doing so come to the right point of what it then really is, because everything else was eliminated.
Exactly. The main thing is to rule out other diseases that can cause a dysfunction or of the nerves, or they cause other diseases where the nerves don't work right, going to your hands or legs and to the blood vessels into the skin of your hands and legs.
Right. Well, Dr. Wolski, you brought up something at the very beginning, something I might ask you more about it, but just shed a tiny bit of light on it. We don't have too much time anymore in this particular section, but why is it? I hear that over and over again, frankly, with friends and with people, my mom and my dad and all that, you keep hearing it, and that is, they have certain symptoms. I frankly had it as a child. The worst I can imagine was when I even at a dentist. I tell the guy, I have this pain. The guy says, no, you don't. You are imagining it, or like you're just a sissy, you know, and nothing gets treated. Why is it that a doctor doesn't believe the patient that he has some pain, some discomfort? What is going on? And then the patient learns to live with this pain. What is it about that philosophy with you doctors? With some of you doctors?
That's an excellent point. Some of these doctors may think that the patient is drug seeking. A lot of these people get on medications that are very addictive, and they may think that they're drug seeking. Also,
well, let me right away. Let me stop you here. Does the doctor think he's drug seeking like the way a street druggie, basically street drugs, or drug seeking because he by now is addicted to morphium or whatever the heck you guys you give? Because if he's addicted to medical drugs, well, then obviously he took them for a freaking reason in the first place, right?
Right. That's a very good question. A lot of people take it for pain, but what happens? They metabolize it. What that means, their liver cleans out these medications, so they need more and more medications to do the same job, to relieve the pain, and they get addicted to it. And a lot of these, they needed the medication at the beginning, but they really didn't necessarily have to get hooked on it. There are other methods for treating these type of problems, rather than getting people hooked on massive narcotics.
I see. So I can see a little, kind of a catch-22 or between a stone and a rock or something like that, where people come, they have a pain. The first inclination, number one, the patient wants to get rid of it ASAP. So the doctor complies, gives them strong drugs, maybe doesn't even know any better, but either way, gives them strong drugs. The patient gets hooked on the strong drug because the symptom was never fixed. And next thing you know is the dependency on the drug becomes so much more visible that other doctors say, hey, there's nothing wrong with you. I think you just want drugs or whatever, because that problem becomes so far down in the shadow, it's gone. The drug dependency starts hurting more than the original illness.
That's a very good point, and that happens a lot. And what we try to do in our program is to treat the pain, the chronic pain, with techniques, and we try to taper these folks gradually off of their heavy narcotics that they've been hooked on.
Yeah, I love it, and I love it. I personally, as I speak to you, I'm 58, and I haven't taken a single aspirin since Mom shoved it in me when I was 16, and I'm not proud of it. I'm not unproud of it. It's just how it is. But I definitely think this is a good direction, and again, the public seems to be waking up, because the trend towards trying to fix things for real rather than masking them up with drugs seems to be a huge trend in the population. Dr. Wolski, we're out of time. Thank you very much. Bye-bye.
Okay.